This is Insta question 1. Identify the reason behind the integrity of the cell wall of M. tuberculosis bacillus. Wax-D, peptidoglycan meshwork, lipopolysaccharide, dipicolinic acid. Okay, let me make it very clear to you. MTB as a bacillus is a very tough customer to beat. It is a very tough customer to beat in terms of cell wall integrity. And that cell wall integrity is important to bring out a particular property called as acid fastness. Do you remember what is acid fastness? When I throw sulfuric acid, hydrochloric acid or acetic acid on the surface of the organism like MTB, it is able to resist the attack of acid. So in spite of the acid attack, the organism is able to stay stronger. It is able to hold on to the primary dye. That is called as acid fastness. In simple terms, it is resistant to acid. The resistance to acid can be because of both dipicolinic acid and wax-D. What is wax-D? Wax means the lipids who are solids at room temperature. Here we have the wax called as mycoside trehalate. And this mycoside trehalate is made up of the fatty acid called as mycolic acid and the sugar called as trehalose. The fatty acid will bring the COOH group, while the trehalose will offer the OH group. The bond between the acid and the alcohol will be called as ester. So wax-D is a type of ester. Dipicolinic acid is also capable of resisting acid, but the difference is that dipicolinic acid is not found in the wall of MTB. It is found as a part of the spore wall. So dipicolinic acid offers the integrity for the spore wall, while the wax-D is the one who offers the integrity for the MTB bacillus wall. Remember, peptidoglycan meshwork is just a particular meshwork who's acting as a part of your gram-positive cell wall, and that is not going to be very tough to resist acid. It is only capable of being a gram-positive organism. And lipopolysaccharide is not a very tough structure. It is nothing but the endotoxin that is present in the outer membrane of a gram-negative organism. So this is the theory to explain the question. Wax-D contains mycolic acid and trehalose. The presence of mycolic acid makes the bacteria resist the attack of acid. Peptidoglycan meshwork can only give you a gram positivity for the organism. Gram positivity means resistance to alcohol, and that does not mean there is a resistance to acid necessarily. And dipicolinic acid helps in the structural resistance in terms of spore wall. Thank you. Hi people, this is to Biomed Insta question 2. Among the following, which is the most helpful for rapid diagnosis of M. tuberculosis? Is it Negrosin stain, Orman-Rodeman stain, Giemsa-Reich-Giemsa stain, or a Ziehl-Neelsen technique? Let's begin with the first option. Negrosin stain is important as a negative stain, and this is also referred to as India ink preparation. The word negros stands for black. Though it can be a racistic word, remember it is capable of giving you a black background, and this is capable of giving you a negative staining. What do you mean by negative staining? The structure to be demonstrated is not stained. While the background is stained, the organism appears brighter in front of the background. What is Orman-Rodeman stain? These are two important stains which are useful for fluorescent microscope. Let me tell you the meaning of the word fluorescence. If I throw light of a particular wavelength onto a substance and that substance gives out light of a different color, that is called as fluorescence. I repeat, if I am supposed to attack a particular structure using color or a light of a different color, for example 350 nanometers is the color I use, if it is capable of giving me a different color like 470 nanometers, then that is called as fluorescence. And the right answer is Orman-Rodeman staining, which is capable of giving you a rapid diagnosis of M. tuberculosis. Why? If at all the organism is existent, if MTB bacillus is existent, the moment you attack the organism using the stain, when the stain touches the organism, instantly it glows like a flower. You will be able to see it very clearly like a flower, and you will be able to measure every single bacillus very clearly. Giemsa-Reich-Giemsa stain in bacteriology is useful in case of analyzing and looking at Borrelia. Ziehl-Neelsen technique is the standard modified acid fast technique meant for mycobacteria and for all the organisms under the order Actinomycetales. Here I want you to understand one thing. Ziehl-Neelsen technique can be useful for M. tuberculosis, understood, but it is not giving you an answer as a rapid answer. While in case of Orman-Rhodeman staining, you can get answers rapid fast. In a matter of seconds to minutes, you'll be able to get the answer. Let's look at the theoretical explanation behind this. Orman, rhodamin, lissamin, sodium thiomalate are the fluorescent dyes used in case of fluorescent microscopy. And what is the contraindication for sodium thiomalate? The technician is not supposed to use any kind of gold ornaments in his fingers like rings, because the gold can react with sodium thiomalate to form orothiomalate, which is capable of causing liver failure. On that reason, if you are using or handling sodium thiomalate, you're not supposed to use gold in your fingers. The microscopy is best for rapid identification of tuberculous bacilli if it is fluorescent microscopy. So this is our discussion for the question. Thank you. Hi people. This is Stupamine Insta question number 3. Among the following, who has the least risk for active tuberculosis in patients who are infected with MTB bacilli? A. Chronic infection with HIV. B. Chronic renal failure. C. Diabetes mellitus. D. Jejunal bypass. Okay, the right answer would be diabetes mellitus. When I tell you this, you might be shocked, because you have learned all the time that diabetes mellitus is a state of immunodeficiency. It's a state of immunodeficiency. Let me make it clear how exactly DM can be a state of immunodeficiency. Point number 1, this diabetes mellitus is important because of poor glucose uptake into the cell. And glucose uptake is primarily important for glycolysis, which is the basic metabolic pathway for production of ATP. So diabetes mellitus has its maximum effect on neutrophils and generally the humoral immunity system. At the same time, you have to understand diabetes mellitus is a state where the hyperglycemia can help the organism survive more if at all the bacteria can utilize the glucose better. In case of HIV infection, T4 lymphocytes are under attack. In case of chronic renal failure and jejunal bypass, the patient who has been infected with MTB can actually go towards a full-blown tuberculosis called as active tuberculosis. While diabetes mellitus is concerned about HMI deficiency more than CMI deficiency, and remember, neutrophils were never the line of defense against that of MTB bacillus, so when the neutrophils are failing, they don't make much of a difference in terms of MTB's control. So remember, diabetes mellitus, though it is present, will not be a very high risk factor in case of conversion of a simple infection to a full-blown disease. What is infection? The mere entry of an organism into the host is called as infection. But the response shown by the host towards the organism along with clinical features which are signs and symptoms is called as disease. So when the infection of MTB becoming active tuberculosis, one of the risk factors which is less would be diabetes mellitus. Here is the tabular column which can tell you the relative risk for each of the conditions. If at all a patient has a recent infection with tuberculous bacilli, he has 12.9 as relative risk versus odds. Look at this. HIV infection is the number 1 risk factor for any patient who has been infected with MTB bacillus to become tuberculosis patient. Closely followed by that would be post-transplant period and jejunal bypass. After that, you can think about chronic renal failure where the patients have gone for hemodialysis as one of the most important risk factors. But when you try to compare diabetes mellitus, this would be just 2 to 4 as a relative risk ratio as given by Harrison. Thank you. Hello people, this is Stupamine Insta question number 4. Which of the following is false with respect to tuberculoid leprosy? A. Tuberculoid leprosy is the most severe end of the spectrum of leprosy. B. Spectrum of tuberculous leprosy encompasses TT and BT disease. Symptoms are confined to the skin and peripheral nerves. D. TT or BT leprosy is the most common form encountered in India. Let me begin by telling you the spectrum for leprosy. As we start from the best of the investigative spectrum, in terms of immunity, the best spectrum would be tuberculous leprosy. Slowly, when the patient has lesser and lesser immunity, it becomes tuberculin, but it's a borderline. You call it as borderline tuberculous. Then we have something called as borderline. Then we have something called as borderline lepromatous. And the worst situation would be lepromatous leprosy. If I perform lepromin test, it will be positive for tuberculous leprosy and negative for lepromatous leprosy. That is an indication to tell you the prognostic power of the particular test called as lepromin test. Here in tuberculous leprosy, the CMI is present, intact and fights against the organism. In lepromatous leprosy, the CMI is present but not able to or not willing to fight against the organism. So, tuberculous leprosy is the best immune status, while lepromatous leprosy is the worst immune status. So, this would be the severe end of leprosy. That makes option A the right answer and the false statement. B. The spectrum of tuberculous leprosy encompasses tuberculoid and borderline tuberculoid. That's a true statement. So, here tuberculoid leprosy and borderline tuberculoid belong to the spectrum of tuberculous leprosy, while if you think about the lepromatous leprosy spectrum, you will have both lepromatous leprosy and borderline lepromatous. Symptoms are generally confined to the skin and peripheral nerves. The reason being they are the cold parts of your body where the temperature is not the same as the core body temperature. TT and BT leprosy is the most common form encountered in India, and that's a true statement. And according to Harrison, option A is the false statement. At the less severe end of the spectrum is tuberculoid leprosy. In general, these forms of leprosy result in symptoms confined to skin and peripheral nerves if it is tuberculoid leprosy. AFB are generally absent or fewer in number in case of tuberculoid leprosy. Tuberculoid leprosy patients may have asymmetric enlargement of one or a few peripheral nerves. But if it is lepromatous leprosy, it will involve more number of peripheral nerves. The skin lesions of tuberculoid leprosy consists of one or a very few hypopigmented macules or plaques. But if it was lepromatous, it was spread all over the areas. It can cause a deformation of your face, which can be referred to as leonine phases, which is absent in case of tuberculoid leprosy. Hope it helps. Thank you. Hello people, this is Insta question number 5. The main purpose of performing a throat culture is to detect the presence of A. Neisseria meningitidis, B. Staphylococcus aureus, C. Streptococcus pneumoniae, and D. Streptococcus pyogenes. Okay, so this will bring us to the question. Throat culture is most commonly performed for the sake of infections that can attack your throat, that is pharynx. So any organism who is capable of causing pharyngitis consistently would be the most common answer for this kind of questions. Neisseria meningitidis is not an organism known for causing pharyngitis. The question and the option has been very close. Here, gonococcus would have been the closest answer because gonococcus can easily cause pharyngitis and sore throat. So we will not be culturing it for Neisseria meningococcus. We may culture for Neisseria gonococcus. Staphylococcus aureus as such is not an organism known for causing pharyngitis. Though it is very well capable of causing pharyngitis, it is not consistently known for causing pharyngitis, and so I will not be doing it for Staphylococcus aureus. Streptococcus pneumoniae is known for causing orbital cellulitis. You will be having otitis media, and also it can cause pneumonia with some kind of keratitis. But Streptococcus pneumoniae is not known for causing pharyngitis, while Streptococcus pyogenes can attack two parts of your body. One is your skin, the second is your pharynx, and they are referred to as dermatological strains and pharyngitis causing strains. And these two kinds of strains can go for secondary immune response, which are delayed antibody mediated responses. Here, the one other organism that you can think of when I speak about throat culture would be Corynebacterium diphtheriae or diphtheroid organisms. So two first group of organisms you have to think of when you're performing a throat culture to detect the presence of organisms. The answer would be Streptococcus pyogenes and Corynebacterium diphtheriae. While Streptococcus pyogenes can cause pyogenic pharyngitis, diphtheria is known for causing membranous pharyngitis, and that would make all the difference. Here, in case of Streptococcus pyogenes, still penicillin is a wonderful choice. But before choosing your antibiotic, please go for warm saline gargle, and that should be a very strong kind of gargle. The first thing you do in the morning and the last thing you do in the night. That is a wonderful way of dealing with the organism. Then we can try attacking the organism using penicillin or erythromycin. The same in case of Corynebacterium diphtheriae, you can go for erythromycin group of drugs which can be inhibitors of protein synthesis. Thank you very much. Hello people, this is Tupaimate Insta question number 6. Pick the pair whose exotoxins act by ADP ribosylation. A. Clostridium tetani and Bacillus anthracis, Clostridium perfringens and Staphylococcus aureus, Corynebacterium diphtheriae and Escherichia coli, Enterococcus faecalis and Mycobacterium tuberculosis. The second response is the wrong answer. The first response is slightly a wrong answer. The third response is a very wrong answer. The right answer would be option C, Corynebacterium diphtheriae and Escherichia coli. I'll explain you how. If I start with Clostridium tetani, the two major toxins are tetanospasmin and tetanolysin. Where tetanolysin is not involved in clinical feature, it speaks about the lysis it causes on blood agar plate, while spasmin is the one who deals with the mechanism for pathogenesis. Well, spasmin's primary function is to inhibit the release of GABA and glycine, which are inhibitory neurotransmitters, so that they cause consistent contraction, which is called as spastic paralysis. Bacillus anthracis exotoxin has two fractions. One is called as edema factor, the other one is called as lethal factor, which are clinically relevant. The third not clinically relevant factor would be protective antigen fraction. Here, the protective antigen fraction is only immunologically important, while the edema factor and lethal factor are known for causing localized edema with the rim of edema at the central caseous necrosis or non-caseous necrosis. It can cause a particular lesion called as malignant pustule. It is black necrotic area with the rim of edema, and this can also be referred to as eschar. And the mechanism is by activation of cyclic AMP in case of edema factor, and in case of lethal factor, it is by inhibition of MAP kinase. When it comes to Clostridium perfringens, the most important toxin is lecithinase, which breaks the lecithin, a phospholipid. Staphylococcus aureus is the king of many exotoxins, but these exotoxins are not related to ADP ribosylation. Enterococcus faecalis and Mycobacterium tuberculosis are not very known for toxins. Now let's come to Corynebacterium diphtheriae. Here, you will be having the particular toxin of C. diphtheriae called as diphtheria toxin blocking elongation factor 2 in eukaryotic protein synthesis. So, how do they perform the inhibition? They cause ADP ribosylation of the elongation factor 2, because of which elongation of translation is actually blocked. So, protein synthesis in eukaryotes is blocked, so the cells may die. Escherichia coli, when you think about the heat stable toxin or the heat labile toxin, they can act either by cyclic AMP or cyclic GMP. If it is heat labile toxin, it is through cyclic AMP. If it is heat stable toxin, it is through cyclic GMP. They open the chloride channel. What they technically do is the toxin will cause ADP ribosylation of G proteins. Toxin can cause ADP ribosylation of the G protein and keeps the G protein in the continuously active state, because of which chloride channel is continuously open. When the chloride channel is opened, then through the particular channel, lot of chloride will be lost into the lumen. As chloride is lost, you will lose sodium, which follows it, and sodium is hygroscopic, so water is also lost into the lumen. This is called as loss of water, and electrolytes called as sodium and chloride, which is diarrhea. Thank you. Good evening, people. This is Stupimed. Insta question 7. The drug of choice for atypical pneumonia caused by Mycoplasma pneumoniae is A. Amoxicillin, B. Azithromycin, C. Ceftriaxone, and D. Gentamicin. Okay, let's understand what classification do these drugs come under. Amoxicillin is a classical example of a cell wall synthesis inhibitor. Ceftriaxone is an example for the same class called as cell wall synthesis inhibitor, but amoxicillin comes under beta-lactams called as penicillin group of drugs, while ceftriaxone comes under beta-lactams, which are cephalosporins. What is common to both of them? Both these drugs will inhibit the formation of a cell wall. Gentamicin is an aminoglycoside who is important for protein synthesis inhibition. At the same time, azithromycin is also a wonderful example of protein synthesis inhibitor. The point here is, amoxicillin is a classical example of a bactericidal agent that is also followed by ceftriaxone. Gentamicin is also a bactericidal agent, while azithromycin is a bacteriostatic agent. Remember, the drug of choice in case of Mycoplasma pneumoniae will most commonly be a macrolide. Sometimes it can even be tetracycline group of drugs. Here, The amoxicillin and ceftriaxone who are trying to block the cell wall synthesis in a particular organism will prove to be failure in case of Mycoplasma infections. Why? Because Mycoplasma is a unique organism. It is the tiniest among all the free-living bacteria and does not have a proper cell wall. When it has no cell wall, then what is the point of blocking the formation of a cell wall in such an organism? It is of no use, right? So both amoxicillin and ceftriaxone will be a failure. But gentamicin is an organism which is very heavy in terms of molecular weight. And uptake of gentamicin by Mycoplasma pneumoniae is very poor. Because of it, gentamicin will not play a very good role in case of Mycoplasma pneumoniae. At the same time, gentamicin can be very effective against intracellular organisms, while Mycoplasma pneumoniae may be found intracellularly, but most commonly can be found in the extracellular atmosphere. That is why it can be grown on artificial culture media. Azithromycin is the best drug of choice. It comes under macrolide and it can be a very good treatment in case of atypical pneumonia caused by Mycoplasma pneumoniae. This is the theoretical explanation for the given question. Thank you. Hello friends. This is Stupime Insta question number 8. Pick up the true statement among the following with respect to Haemophilus ducreyi. Option A. X and V factors are both needed to help the growth of the microbe on MacConkey agar. Gram stain of exudate from the lesion shows large gram-positive rods. C. Causes a painful ulcer on the genitalia. D. Penicillin G is the drug of choice to treat this microbe's infection. Okay. Haemophilus ducreyi is an organism known for causing a condition called as chancroid. And this chancroid can be seen on the genitalia. And when the genital lesions are showing up, you can also see the lymph nodal involvement in the vicinity. Remember, chancre or canker caused by Trichoderma pallidum is seen in syphilis, which is a painless lesion. While chancroid is a very painful lesion, not just the skin lesion that is painful, even the lymphadenopathy is painful. So on that basis, option C is the best answer. Let's look at the remaining options. Factor X and factor V are also called as factor 10 and factor 5 by some authors. Be it what may, these factors are both needed to help the growth of the microbe on MacConkey agar is a wrong statement. Because Haemophilus influenzae is an organism who requires both the factors. This organism requires one of the factors. We'll see what it is. The gram stain of exudate from the lesion shows large gram-positive rods is wrong. It shows large gram-negative rods who can not only be seen as rods always, they can also be coccobacilli in nature. They can exhibit pleomorphic property. Penicillin G is not the drug of choice because it's a gram-negative organism. You can think about macrolides or protein synthesis inhibitors which can be very useful. Let's look at the explanation for this question. It's a very small gram-negative STD causing bacillus. It causes painful chancroid and this chancroid begins with penile lesions which are painful and non-indurated like chancre of syphilis. So that's the difference between that of syphilis and chancroid would be that chancre is indurated and this one is not indurated. And you can expect ulcers and buboes also. Remember, the organism requires chocolate blood agar and not your general blood agar. And this chocolate blood agar with X factor called as heme is used, while it does not require the factor V called as NAD. Heme is referred to as factor X, while the factor V is nothing but NAD. Haemophilus ducreyi does not need V or 5, it needs only heme, which is factor X. And chancroid can be treated using your macrolide antibiotics. Because many strains of H. ducreyi produce a plasmid encoded penicillinase, penicillins cannot be used. Thank you very much. Hello people, this is Stupime Insta question number 9. Among the following statements about Yersinia enterocolitica, all are incorrect except it induces mesenteric adenitis that can very well resemble acute appendicitis. B. Its natural habitat is the human oropharynx and there is no animal reservoir. C. It's a gram-negative diplococcus found primarily within the neutrophils. D. It's the most common cause of enterocolitis. Okay, what exactly the question wants? They ask us to find out the correct statement. Why? All of the following are incorrect except is the question. So these kind of things are trickier. When they say all the following are correct except, look for the wrong option. All the following are incorrect except, look for the right option. Please remember, the question may be very simple, but you may make a mistake at this level because you are in an urgency to finish the question and go to the next question. Please don't be haste. Haste makes waste. So please be careful, read the question properly. So first decide, what are you looking for? You're looking for a true statement. Okay, it induces mesenteric adenitis that can very well resemble acute appendicitis is an absolutely true statement. Why? Because Yersinia enterocolitica, another organism called as Yersinia pseudotuberculosis, both are known for causing appendicitis-like illness which can resemble a proper appendicitis. So option A is absolutely true. It is mesenteric adenitis. Look at option B, C and D. They have to be false. How are they false? Its natural habitat is the human oropharynx. That is not correct. Yersinia enterocolitica may be found rarely as a commensal in your GIT in the lower intestine, but not in the oropharynx. And there are possible human reservoirs and animal reservoirs also. It's a gram-negative diplococcus found primarily within the neutrophils? No. Option C is the classical description for either a gonococcus or a meningococcus, because these two organisms are proper gram-negative diplococci and they are intracellular inside the neutrophils. Option D, it is the most common cause of enterocolitis? No. You know what exactly is the most common cause of enterocolitis. It can be Shigella, Salmonella and E. coli. If you take into consideration among the three, E. coli may be a leading cause of all these things. Look at the explanation here. It's a gram-negative diplococci of significance would be gonococci and meningococci. H. ducreyi is a coccobacillus. At the same time, Yersinia enterocolitica is also a coccobacilli according to a few authors. And these Yersinia enterocolitica are not present in the oropharynx and less frequently known as commensals in the intestine. And these can be isolated from stool specimens and form a lactose negative colony. So remember, they are non-lactose fermenters. So being commensals would be a very rare chance, because most of the lactose fermenters can be commensals in your GIT. Yersinia enterocolitica causes enterocolitis that is similar to that of Salmonella and Shigella. And remember, they grow better at 25 degrees Celsius than at human body temperature. So most biochemical results are given as a positive answer at 25 degrees Celsius. This should be remembered for your central exams. An incubation of stool sample for 1 week at a temperature of 4 degrees Celsius is referred to as cold enrichment. This MCQ can be repeated in any of your exams. So remember, cold enrichment is a technique that you have come across, the organism called as Yersinia enterocolitica. Thank you. Hello people. This is Stupamite Insta question number 10. Which of the following microbes is believed to be the first to satisfy Koch's postulates in its earliest period? A. Neisseria gonorrhoeae, B. Mycobacterium leprae, C. Bacillus anthracis, D. Treponema pallidum. This is technically an easy question because Neisseria gonorrhoeae, Mycobacterium leprae and Treponema pallidum all are learnt as those organisms who defy Koch's postulates. That would be the answer of elimination called as Bacillus anthracis. I can easily choose Bacillus anthracis as an option because of elimination of the remaining options. But let us try to understand what exactly are Koch's postulates. When Koch came to tell you that the microbes are the reason behind infectious diseases, people did not believe him. So he came up with a postulate and he wanted to say that that microbe is strongly attached and the causative organism behind a disease by taking forward 4 important statements. 1. The bacteria must be present in every case of the disease. Point number 2. The bacteria must be isolated from the host with the disease undergrown in pure culture. Point number 3. Specific disease must be reproduced when a pure culture of the bacteria is inoculated into a healthy susceptible host. Point number D. The bacteria must be recoverable from the experimentally infected host. What exactly you mean? If at all I see a disease process with a lesion in my skin or anywhere in my body, if I try to probe for the organism, I should be able to find the organism every time on the lesion caused in the disease. Second, I should be able to isolate the organism from the lesion. Then I should be able to culture the organism from the lesion. Then I should be able to make a pure culture of the organism which actually has been isolated. If it is injected into another organism or another host, it should be able to create the same kind of disease again. And from that experimental host also, I should be able to isolate the organism. All these 4 are called as Koch's postulates, which are very tight rules. On that basis, many organisms failed to satisfy Koch's postulates. Point number 1. Why gonococci does not satisfy the Koch's postulate? Because when I spoke about the extraction of the organism, isolation and putting it into an experimental animal, you need the experimental animal also to show you the same reason and the same clinical condition, right? But if I try to inject gonococcus into a cow, cow will not suffer from gonorrhea. A dog does not suffer from gonorrhea. Gonococcus is purely a human disease. So it was not able to satisfy Koch's postulate. Point number 2. Why M. leprae failed to satisfy Koch's postulate? Because M. leprae is not culturable at all in vitro. You need a live host to culture the organism like footpad of mice and nine-banded armadillos. And then comes the other organism called as Treponema pallidum. Like M. leprae, pathogenic Treponema pallidum cannot be cultured in vitro. Maybe you can actually maintain them by serial passage through rabbit testis, but you won't be able to culture them. You will be able to maintain them alive, but you won't be able to culture them if they are pathogenic. So on that basis, the one single organism who was known to satisfy Koch's postulates in the earliest time was Bacillus anthracis. Okay, a harmless bacteria may cause disease if it gains virulence so that it can become pathogenic. Also, if the organism gains access to deep tissues via trauma, surgery or IV line, the organism can cause disease in an immunocompetent patient. So all these things are telling you that the harmless bacteria can also cause a disease process. You can't clearly say that whether all the organisms are absolutely harmless. Not all people infected by a bacteria may develop disease. Subclinical infection is usually more common. So right now, you are trying to look for the discrepancies in the statement that if there is an organism, there should be a disease. If there is a disease, there should be an organism. That thing is broken right now. If an organism is there, disease need not always be there. It can be a subclinical infection also. So I hope you will be able to use this information to answer a few of your MCQs. Thank you.